My name is Hayakawa. I'm a cardiovascular interventionist from Japan. I'm very happy to be here. My presentation is about minimal contrast endovascular treatment. So at first, an EVT for a patient with CKD can be problematic because of the risk of CN, as you know. Various methods for preventing CN have been reported. However, there was no consensus. So we usually use carbon dioxide angiography or IBIS-guided approach. However, they have their own weak points, such as the complications and imaging quality. So we now have made a DSA program with a specialized diluted contrast, and we named this method low concentration DSA, LC-DSA. So we adjusted the DSA parameters like this and Philips and the Canon's angiographical machine. And a very high contrast with low edge gain because of the noise reduction. And we used 10% diluted contrast that is almost equivalent to CO2 DSA. And we injected manually about 5 to 10 milliliters per shot. And this is a static image. We can get a beautiful image with a small amount of contrast. So this is a case, 70-year-old male, severe claudication and less pain. Both ABA was reduced, and he had a CKD and a creatinine, and EGFR was DS. This is a control angiography using diluted contrast. And each DSA shot needed under 1 milliliter of contrast medium. However, we could get a beautiful image. The CTO was SFA distal to P3 segment. This is a static image. We could identify the collateral connection like this. So at first we performed the antegrade wiring with the O14 guide wire. However, the CT was very hard, so an antegrade approach was difficult. So next, and we were switching to retrograde wiring. We chose this collateral connection, and we performed the trans-collateral approach with low concentration DSA. This is a roadmap by the LC-DSA, and this is a tip injection. The CTO site was blunt and seemed to be very hard. So I used an Astat 940 14 gram and tapered stiff wire. And finally, we could achieve landable in the CTO site. So next, we recrossed to ATA like this. And finally, we could get all interluminal wiring. After that, we performed the ballooning and the scoring balloon and the kissing balloon dilatation and the long balloon with long inflation time. This is the final angiography. There were no residual stenosis and there were no major dissection, as you can see. And moreover, we could identify the distal BTK2 below the ankle and the small channels and the brush well. And the contrast medium is under 30 milliliters, even if this is a complex procedure. Linear function was well preserved, and our clinical course was very well. And this is discussion. The comparison of normal DSA and normal DSA with diluted contrast, a very faint image, but using LC-DSA with 10% contrast, we could get a very beautiful picture like this. And this is a comparison with CO2 angiography in the BTK region in the same patient. And imaging quality is better than CO2 DSA, like this, and which is better. And in this year, we published this method. And we analyzed the 63 LC-DSA patient versus 59 standard PTA patient. Over 50% CLI and over 60% CTO, very hard, tight lesion. However, the CIN was 0% in LC-DSA group, and the total contrast volume was dramatically reduced. So this is a key slide. We performed the diluted contrast angioplasty. Efficacy is a small amount of contrast medium and a sufficient quality of angiography. And the safety is there were no complications, and the CN rate was very low. And strong point is we don't need any special technique and devices. So that we can perform EVT for CKD patient without lowering quality. So this is my conclusion. We experienced very tough case using diluted contrast angiography, and LC-DSA has a possibility of being useful for treating CKD patients. Thank you for your kind attention.
Dr. Hayakawa, you make a very important point. First, you show a good technique for transcollateral. More importantly, that the CO2 angiography sometimes cannot show below the knee arteries, and here you have contiguous disease. So can you point us some tips and tricks, which collaterals one should use and which one? Are there size criteria, tortuosity, or there is a Japanese classification I'm not aware of?
Which collateral?
For transcollateral crossing. How do you select the collateral?
At first we check the DSA angiogram, and we check the collateral size and collateral size and the tortuosity. So in this case, a very relatively straight and vessel size was acceptable. So I chose.
Is there a minimum diameter?
About 1.5.
1.5 millimeter.
Yeah.
Thank you very much. That's what I was looking for.
Thank you very much.